A very good day to you all. Today we'll be discussing a new technique or an alternative technique of placing stainless steel crown, which is known as the Hall's technique. The Hall's technique gets its name from Norna Hall, who was a Scottish private dental practitioner who had been practicing this Hall technique of placing stainless steel crown for the past 15 years, and she retired in 2006. At the same time, Dr. Innes, the Dean of Pediatric Dental Department, Dundee Dental School, published her work, and it was said that this was very convenient among the general practitioners practicing a little bit of pediatric dentistry. But the British Society of Pediatric Dentistry, as well as the American Academy of Pediatric Dentists and the pedodontists all over the world, there was a little bit skepticism in accepting Hall's technique. But with a lot of random clinical trials and literature work and research works comparing Hall's technique with the conventional placement of a preformed metal crown, that is stainless steel crown, and they found that this is equally good and effective, and there's no much problems, difficulties with this, and probably for a practitioner, general practitioner, this may be an alternative technique to manage dental caries. So simultaneously, the American Academy of Pediatric Dentistry in 2016 has, has proposed that this Hall technique is nothing but placing a stainless steel crown over a carious primary molar without any caries removal, tooth reduction, or giving a local anesthesia even. So it is very comfortable for the children, and it has been accepted as a part of caries management program. Now, why stainless steel crown is coming as a restorative uh, armamentarium in pediatric dentistry? Now, we should go back to the beginning of stainless steel crown that was introduced in 1950 by Humphrey Davy. And at that time, the best material to restore a tooth was silver amalgam. But whenever there is a proximal cavity in a primary molar, that restoration was found to be not lasting very long. And then came the composites with the acid etching technique. And then glass ionomer was introduced by the 60s and 70s. And even now, glass ionomer is accepted, or the versions of various modified versions of glass ionomer is accepted as the best management for primary tooth decay. Whatever it is, the success rate of amalgam restoration, composites, or glass ionomer, whenever the marginal ridge was involved, was found to be comparatively lesser as when compared to a stainless steel crown placed over a caries, multi-surface caries tooth. The longevity of the restoration is found to be more. So Ostland and his co-workers, when they compared the class 2 restorations of amalgam, composite resins, and glass ionomers, they found that the glass ionomer failure rate was 60% after 1 year, while that of an amalgam and composite was 8% to 16%. And further, Louis Alexandre has found that the restorations of primary teeth, a systematic analysis was one done, and it was found that stainless steel crown, when placed, were a much higher success rate, 90%, 94%, and above, as compared to glass ionomers or other restorative materials. Let's take a little bit reason why my restorations fail in a primary tooth. Now, there are reasons for multi-surface restoration failure in primary tooth. Basically, that is credited to the anatomy of that particular tooth, especially the first primary molar. We have a very narrow occlusal table, so the width of the cavity is very less. The less tooth material is covering. All around the tooth material covering, the pulp is very less. The average enamel thickness is just 1 mm. We have a large pulp chamber, and there is a wide proximal contact area. So there will be little bit of losing tooth structure whenever we prepare a proximal cavity in order to break that broad contact areas and for the matrix to pass. More than that, there is a marked cervical constriction. So if you are looking at that small decay there in the picture, it's such an innocent looking decay where we all feel that we can just excavate and fill it up with a glass ionomer or any material. The moment you start putting your burr, then you can see that you are ending up in a no man's land. That is mainly due to the cervical constriction. So we would love to take a good wide gingival seat. The more wider we go with our gingival seat preparation, big chance of pulpal exposure. So a small filling for it to retain to successfully, it might end up with a pulpal exposure. So any physics says that the proximal cavity or the pyramid shape, that should be the best to control a load on that. But in all probability, our proximal decay in that first primary molar may be the reverse direction of a pyramid. And there is a big chance when masticatory occlusal loads come on the marginal ridge and our restoration can fracture there. Moreover, the primary tooth, when we go for newer restorative material, the adhesive restorative material, restoration additions can be a bit of problem due to the prismless enamel. The big bonding may be not that as effective as in permanent teeth. So, American Academy of Pediatric Dentistry, the latest evidence-based dentistry says that if you look into that evidence base against class 2 restoration and glass ionomer, we can see that it is evidence against. The red line shows that. But if you look at the stainless steel crown, it is evidence in favor of placing a restoration for class 2 restoration. So all in all, the crowns may be better in a proximal decay. Now the principle around the deep vital caries management is revolving around three kind of management. First is maybe a complete removal of caries and restoration. Two, it can be a two-step, that is first a incomplete or a partial removal of the caries followed by a temporary filling and then a restoration. And there is one more mechanism of managing deep caries. Either we don't remove any caries, we directly fill it up. Our Hall technique comes in that category. Now, the principle why caries management successful in Hall technique is that the environment conducive to decay is cut off and the lesion doesn't progress further. And then this Hall stainless steel crown, when placed like in a Hall technique, that is lasting till the till the life of the tooth. So it is a long-lasting retention is very good with the crowns, and normally the tooth exfoliate along with the Hall technique. So that is the caries management principle along with Hall technique. Now, if you look into the indication of Hall technique, it's for young children, cooperative children. At least they should be cooperative enough to clench their teeth once a crown is placed. When we look into the decay aspect, it is always done in a vital pulp, never in a non-vital tooth. We can go for conventional crown for a non-vital, but not Hall's technique. Occlusal, either proximal or a multi-surface decay, fine, doesn't matter. And a doctor also should be a little bit adapted in stainless steel crown technique. For a newcomer, I will not recommend go directly to Hall's technique. Go with the conventional technique. Once you are adept in placement of a stainless steel crown in the selection and placement, then go for, you can change to Hall's technique too. Doesn't matter. But if you look into the contraindications, yes, tooth with signs and symptoms of dental infection or irreversible pulpitis, never to do Hall technique. Crown severely distracted with decay, so as considered as a non-restorable tooth, we cannot place a crown there. And very young children, 1 year, 2 years, when there is no vocabulary support to, or they cannot understand to clench the teeth, those kind of children, we may not be able to place a Hall technique mode of crown, stainless steel crown. The advantages, now there is, you should imagine that there is no cavity preparation, no local anesthesia, and no surgical management. It is a non-invasive procedure with very minimal clinical time required, and so it is very child friendly and less fearful to the patients, and it is atraumatic when there is no surgical management of a caries too. So it can be grouped under alternative restorative technique management. Hall technique can fit into that also. And basically what we are doing, we are sealing the carious lesion and arrest the caries, or at least slow its progress, which ultimately, that is the purpose of any restoration, improves the pulpal health. There are a few disadvantages. At the time, if there is no clearance in the proximal decay, but there is no clearance to place a crown, we may need a two setting. The first setting, we may put an orthodontic elastic separator, and then the next day or the day next, with 2 days, I usually recommend to come after 2 days, and we remove that separator. There will be a space there. We can place the crown immediately. Sometimes we can utilize a primate space if it is evident between the teeth, then it is okay. Secondly, the child has to clench the teeth once the cemented crown is placed on the mouth. Child has to clench his teeth till that cement sets. So if the child cannot understand this in order or this suggestion, then it might be difficult. If it is too young, that might be a problem. Then there is an initial increase in the vertical height, especially if you go for a posterior tooth, second deciduous molar rather than the first deciduous molar. It has been noted that there will be an increased vertical dimension will be there, but it is said that normally within 30 to 45 days this increased vertical height corrects by itself. And when there is an increase in vertical dimension, we always should suggest or suspect a TMJ problem. But for the long-term studies with the Hall's technique, 5 to 7 years has noted that there is not a single TMJ problem reported. After that, the tooth exfoliates and the new teeth will come. So a long-term effect of TMJ to be studied on these subjects, but for the minimal, whatever research we have is for up to 5 years to 7 years maximum. No problem there. Uh, Two other advantages are the restoration lasts till the exfoliation, and if so, there is no need for repeat restoration. So it is a very cost effective than the conventional restoration of an amalgam. Glass ionomer are no more recommended for proximal primary tooth or a composite restoration. Now, conventional, we have a lot of steps for Hall technique, stainless steel crown preparation, which is not there for the Hall technique at all. We just have to evaluate the tooth. It should be vital. Occlusion, you can look, but even if you don't look, there will be an increased vertical dimension when you place without a occlusal reduction. Fine, accepted. It will get self-corrected now. Crown selection, that is very important. And crown adaptation on the tooth. When you place it, it should be rock fit or stable, not be rocking. It should be good fit on that. Then you cement it. The most common cement used is a glass ionomer cement, type 1 luting agent. Then you place it, and then the post-operative instructions. So the pictures are borrowed pictures, not mine personally. So usually we do elastic separators. We can see that if the primate spaces are available, we may not need that. But in this case, two elastic separators were placed distal to the first deciduous molar. Mesially, it was not there because of the primate spaces. And normally, when I usually apply a little bit of silver diamond fluoride in the proximal decay when they come for that elastic separator placement. So once that separator is removed, then we clean up that area with a little bit of polishing paste, clean up and settle it clean. Select the most appropriate crown, just snap over it and then cement it. And the excess cement we wipe over with a cotton and a dental floss in the interdental area. So in the next slide, we can see the separator is getting removed. There's a little bit of decayed tooth. Or a darkened teeth also due to SDF. Doesn't matter because a crown is going to come on top of that. A crown loaded with cement is placed over, and we remove the excess cement and floss that interdental area. And there we see the post-operative bite. First deciduous molar, the increased vertical dimension may not be too much. But if you go for a second deciduous molar, there will be a little bit of increased vertical height, which is self-correcting according to the research. So this is not again my picture. Dr. Innes has shown that she had placed posterior crowns and there was an increased vertical dimension as you see in that middle picture. But after 1 year, when she came for a checkup, that is settled. The counter argument they give for increased vertical dimension is that whenever we place an orthodontic posterior bite plane, there will be a definite increase in height, but that doesn't always cause a TMJ problem. Same thing these people are saying with Hall technique, there will be an increased vertical dimension which is self-correcting. Uh, Many randomized clinical trials over Hall technique versus conventional stainless steel crown was conducted. Many studies, whether Ludwig's or LM, all says that they have equal statistical results as per the conventional success rate of the conventional crown placement and with the stainless steel crown placement and with the Hall technique placement. This graph particularly shows a comfort level of placement of a stainless steel crown, conventional versus um, Hall technique. And we can see that in that the worst category, significant unacceptable pain is there. Again, that is less in the blue column, that is the Hall technique as compared to conventional stainless steel crown. Now, to conclude, Hall technique is an effective armamentarium in the management of caries primary tooth. It's a viable alternative to manage children atraumatically. And although Hall technique not superior to conventional crown technique, in restricted situations, it can be considered due to acceptability, longevity, and effectiveness. So, thank you.